My name is Elizabeth Fust. Feel free to call me Liz. I am the founder and president of a nonprofit corporation in Louisville, Kentucky called Gathering Strength. I have a spinal cord injury myself, and Gathering Strength is a nonprofit that is led by people with disabilities, and we are collaborating with Fraser Rehab Institute, which is the largest rehab hospital in Louisville, well, in probably Kentucky. And we are collaborating to implement a Craig H. Nielsen Foundation grant, and that grant is responsible for supporting this programming. So I want to introduce the two speakers, and what I'll do is I'm going to go to speaker mode, and then I will spotlight them as they speak. And they're each going to speak for about 25 minutes, and then we are going to have questions from the audience. What I'd like is for folks to put their questions as we're going through in the chat, and I'll use that to ask questions. If you cannot type into the chat, feel free to, when we get to the question and answer piece, feel free to unmute and say that you'd like to ask a question. What we're going to do is try not to have any one person monopolize. So my plan is one question and one follow-up. If nobody else has questions, then folks can ask another question. I'm going to do my best to track all the questions coming in the chat. If I happen to make a mistake, please let me know. And so let me start by, we're going to start with Christopher West. And Christopher West is an associate professor at the Center for Chronic Disease Management and Prevention at the University of British Columbia, Canada. He's a translational research scientist who investigates the autonomic and cardiorespiratory consequences of spinal cord injury and the relationship between physical activity and health. And we also have with us David McMillan. He's a research assistant professor in the Department of Neurological Surgery at the University of Miami and the director of education and outreach at the Miami Project to Cure Paralysis. Dr. McMillan conducts clinical research to understand cardiometabolic disease in people with spinal cord injury. I am thrilled and lucky and pleased, and we should have a great talk today with these gentlemen joining us. So let me spotlight Chris. Where'd you go, Chris? There you are. And okay, Chris, take it away.
Okay, excellent. Are you seeing my presentation okay, Liz?
Yes.
Okay, wonderful. Well, thanks so much for coming today. This is my second time working with Liz, and it was really great last time. So I'm looking forward to a great discussion. And what I thought I would do to start with is just, I guess, share some of the experiences that we've been working on in the lab over the past 10 or 12 years around the topic of autonomic function and exercise. Liz chose this topic for me, so it's a topic that's of great interest to me. It's also a little tricky to speak on, so this should be fun. So yeah, looking forward to getting into it. So, and this won't come as a surprise to many people on here, but there exists in the field of spinal cord injury some really good ways in the clinic to be able to classify someone with spinal cord injury. But this is almost exclusively done for motor function and sensory function. And clinicians, as many of you will have seen this form, will go through and fill out this form. But what's often not done, it is starting to be more, of course, and something that many individuals with spinal cord injury struggle with or have an impact on, is the autonomic nervous system. Now, I'm often asked, well, if this is a key priority for people with spinal cord injury, why don't clinicians do a better job of classifying autonomic function at the time of injury. And well, I kind of like to put this up because this is the answer. It's an extremely complex system, the autonomic nervous system. And what I'm going to try and do today is take this system, focus on the key parts, and simplify it, and with a lens of looking at how autonomic function and changes impact the cardiovascular system. So in particular, the heart and blood vessels, which kind of sit in the middle here. And then what role this might play both in how individuals with spinal cord respond to exercise, and also how efficacious or how good physical activity interventions are, for cardiovascular health. So with that, if we try and look just at the cardiovascular system, and this is going to be, I guess, one of the key slides to this whole presentation. So if you can follow along on this slide, the rest of the presentation will come nice and straightforward. So what I'm showing here is an image of the spinal cord. And I'm going to focus on two key parts, the blood vessels and the heart. Now, what the blue line shows and what the green line shows is how these systems are controlled. You know, just like our legs are controlled by our nervous system, our heart and blood vessels are also controlled by our nervous system. The difference is that these are controlled by our autonomic or our automatic nervous system. Now, the key feature of the autonomic nervous system is it's arranged into these two separate parts. So we have one here shown in blue, and this is called our parasympathetic nervous system, and it's responsible for slowing everything down. So it will reduce resting heart rate. It will help with digestion. And then we have this other one here shown in green, and this is our sympathetic nervous system. Sometimes people will know this as the fight or flight system. It's what increases heart rate and it increases blood pressure during exercise. The real key difference is where the two nervous systems originate with respect to the spinal cord. So the blue, you can appreciate the nerves come out above the spinal cord. So this means wherever anybody has a spinal cord injury, the nerves that control this part of the nervous system are spared. They're not impacted directly by the injury. Conversely, the nerves shown here in green exit the spinal cord around the mid to upper back, and they actually stretch all the way along this whole thoracic region, these nerves. So what this means is if somebody has a, let's call it a functionally complete injury in the cervical spinal cord or tetraplegia, then control over these nerves shown in green are lost. And so what this means, considering those nerves go on to innervate all blood vessels and the heart, is if you think about things like blood pressure, blood vessel function, heart function, cerebral vascular function, cognition, all of these things are impacted and controlled by the sympathetic nervous system. And so if somebody has an injury here, tetraplegic in the cervical spinal cord, control over this system is lost, which will change how these systems respond to exercise. And these are usually the key systems that we want to respond well to exercise in order to reap the cardiovascular health benefits. So I'm just going to give you a few examples of what that might look like. So if we look, let's just take the most, I guess, straightforward form of exercise that many individuals with spinal cord injury take part in, and that would be arm exercise. And what you're seeing here is just how much blood is ejected from the heart at rest and then during different levels of peak exercise. I'm going to show this. The blue is for tetraplegics and the red is for paraplegics. What I'm embedding in here is the response that you would see in somebody without a spinal cord injury. And so if we just take the total volume of blood pumped out of the heart, what is immediately appreciable is that somebody with cervical spinal cord injury or tetraplegia, there's really not much of an increase in cardiac output during exercise. Conversely, paraplegia, and this is low paraplegia, so these individuals had an injury between around T8 and L2 spinal levels, they see this nice linear increase. So as you increase your exercise intensity, amount of blood pumped out of the heart increases. And this, in fact, is exactly what you would see in able-bodied individuals. We can break this down and we can actually see that really, if we talk about stroke volume, how much blood the heart pumps with each beat, similar response. Now, there are some important differences in able-bodied. We don't have to go into this, but regardless, you would expect to see that stroke volume goes up. And so this is really I guess this was one of the first figures I ever saw when I came into researching in the field of spinal cord injury. And I thought, wow, this is something really different is happening here. And of course, what this means, this is just the equation to calculate this, to calculate how much blood is pumped out. You do blood pumped each beat times your heart rate. And what this graph really shows is that all parts of the cardiovascular system's ability to respond to exercise after spinal cord injury is changed. And so this is an important thing to appreciate before we go ahead and look at the efficacy of different interventions, is that just how the system responds acutely to a bout of exercise is different. So this means we probably need to look at things differently depending on level of injury, time since injury, etc. I'm going to do the same now for some of the other key cardiovascular indices we might want to look at during exercise. And I'm going to highlight two main colors throughout these graphs. There's the blue line and there's a green line. The blue line is what happens in someone with a cervical spinal cord injury. Again, this is an injury above that sympathetic nervous system. And then someone with paraplegia or lower level spinal cord injury. And what you can see here, let's just take this example exercise. So someone starts exercising here. And as the individual with tetraplegia exercises, there is an immediate fall in blood pressure during this type of exercise. So blood pressure is unable to be sustained during exercise. And this is why we often see in many cases, if individuals with cervical spinal cord injury exercise for a long period of time, they can actually become quite lightheaded towards the end of exercise. And this is because it can be hard to maintain blood pressure during exercise. And again, this is because that sympathetic nervous system that is responsible for increasing blood pressure isn't functioning as it would be in somebody without a spinal cord injury, or in fact, someone with a low level of spinal cord injury, such as here. A really interesting one, and this will be relevant, Liz, to you today in, where you are with 110 degrees or whatever temperature it is that you have today, is looking at temperature regulation during exercise. So what you'll see here now is different types of exercise. So we go exercise into recovery, into exercise, into recovery. The blue line represents the tetraplegics or cervical spinal cord injury, the green line, the paraplegics. And what would be the ideal thing to see during exercise is that you're able to maintain a consistent core body temperature. And what we see in tetraplegics or cervical spinal cord injury is this increase in core temperature. And that happens because the glands that control our ability to sweat are also controlled by our sympathetic nervous system. So again, depending on the level of injury and the degree of remaining autonomic function, how your body responds to exercise from a temperature control mechanism is also changing. And then this will be the last one I show. And this is kind of a funny one to get your head around thinking about it. But what would happen in an able-bodied person as you start exercising is that most of your blood sits in your abdomen at rest. And what happens is the sympathetic nervous system would constrict those blood vessels, and that enables the blood to be directed towards your muscles for exercise. Now, this is extremely hard to measure in an exercising human, but there's been one study that tried to do this, and they essentially looked at how much blood was leaving the abdominal region with increasing amount of exercises, and indeed saw that in those with intact sympathetic control, low levels of spinal cord injury, you get this reduction in blood flow into the abdominal region, but in those with the higher level of spinal cord injury, that doesn't happen. And so I want to take a moment just to kind of summarize these points here, but there's definitely a distinct response to exercise for the cardiovascular system, depending on level of injury and therefore degree of remaining autonomic function. So I'm going to focus here on the high level spinal cord injury, the tetraplegia or cervical spinal cord injury. And what we see is this small increase in heart rate, really no increase in stroke volume, and this, I'm going to call it reduced ability to be able to redistribute blood to the active muscles. And so when you put all of these things together, this means that when those individuals are taking part in exercise, then the responsiveness of the cardiovascular system isn't the same as what it would have been before injury and isn't the same as those with low levels of injury. And so I'm going to go on now to talk about different types of exercise interventions and the role it has for cardiovascular health, but I'll try and do so taking into account level of injury at the time, because it's really important to look at level of injury when looking at how efficacious or how well these exercise interventions work. Okay, so I'm going to switch gears here now. So we're going to move away from just looking at the acute response to exercise to see, what benefits come from various types of exercise or physical activity interventions. Now, there's, exercise studies are often run in the lab. Physical activity studies also tend to be run in the lab, but we're actually getting better at this now. And in the field of spinal cord injury, especially, there's been a few different types of physical activity interventions that have been run out in the community. And so it's important to understand for interpreting these studies how physical activity is measured. And really, there's two ways that this has been done in the field. The first would be to wear one of these devices shown in red here. It's called an accelerometer. And this essentially tracks all types of movement. If this is run in the context of a spinal cord injured wheelchair user, this would be worn on the wrist. And if this was an ambulator or an individual with spinal cord injury that walked, this would be worn on the hip. And what this enables us to do is to quantitatively assess how much activity or movement an individual gets during the day. So we can see here, this is where the device would be off or the individual would be asleep. And then you measure these counts, and then we can relate these counts to how much activity you get. That's one way to do it. These are costly studies to run in devices. So a more often used way is simply to ask individuals how much physical activity they got over the last 7 days. And this is probably the questionnaire that's been used most. It's just 3 simple questions that asks you about how much light, moderate, and heavy intensity. Of course, the benefit of this is it's easy to administer, but one of the downsides is it's also requires the individual to be truthful and be able to memorize well what's happened over the last 7 days. So with those two in mind, I'll just highlight a few of the studies that I know of that are out there. This is one that myself and Dr. Kathleen Martin-Guinness ran together with a shared PhD student. And what we did here was different. So we said, okay, we're not going to do an exercise intervention in the lab. We're going to actually try and coach and induce behavior change in individuals with spinal cord injury and try and encourage them to get more physical activity out in the community. So this was a very pragmatic trial. We had a 8-week intervention that consisted of a 1-hour introductory session. And then there was a weekly physical activity behavioral consult with a behavior change specialist focused on spinal cord injury. And then we took some measures pre, during, and post. In all of these, for those not used to seeing these types of slides, the text at the very bottom is just the scientific paper that goes alongside the graphs that I'm showing. So if anybody is interested in any of these specifically, I can happily share these papers with you as well. And I want to focus just here on one slide, and this is just what changed with total physical activity before we get into the level of injury. Okay, we saw a remarkable increase in physical activity in this study. I mean, really going up towards 600-700 minutes per week of physical activity following this intervention, which was quite extraordinary. And when we break this down, so the bar would be the total amount of activity, and then we can break this into what we call MVPA, or moderate to vigorous physical activity. And we think this is the one that's important for cardiovascular health. So really a pronounced increase as a group across all individuals. And just so everybody knows that we did do this with a control group that didn't undergo the physical activity intervention. They were just waitlist controlled, so they still had the opportunity to undergo the intervention after the others had finished. So what did we find from a cardiovascular health perspective? Well, here again is the story of the difference in the level of injury. So the good news let me start with this one. I thought this came in the other way. So if we look at this bottom graph, I'm going to orientate you to the figure. So here we have PA means the physical activity control group. These are individuals with an injury level at T6 or above. And then over on the left here is the injury levels of T6 and below. Green is the intervention group and black is the control group. And what we saw, regardless of level of injury, is that fitness increased following the physical activity intervention, which was great. But I'm just choosing one of our measures of cardiovascular health here. So independent of fitness, just cardiovascular health in general. We looked at about 10 different indicators. Every single one of them improved in the individuals with the low level of injury, but unfortunately not a single one of them improved in the individuals with a high level of spinal cord injury. And again, this may perhaps come back to this idea that, well, if the nervous system is responding differently during each exercise bout, maybe that's why we're not seeing the effect. Okay, so what about some different forms of exercise? So another 2 common forms of in-lab exercise is arm exercise or passive leg exercise. And this is probably the biggest trial that I know of to date. It had almost 40 or 50 individuals take part in this across 5 different centers in Canada. And what you can see, again, regardless of, and this I should say is only in individuals with a high level of spinal cord injury. So this was, nobody with a low level of spinal cord injury took part in this. We have 2 interventions here, arm crank exercise or body weight support treadmill training. This was a 6-month intervention, so a very long intervention period. And again, what you can see quite nicely is following the arm crank exercise, you get this nice increase in this same metric, this VO2 or aerobic fitness. Body weight support treadmill training, which is becoming more popular among people, had no real impact on fitness at all. I then just took some example figures showing some of the data across time at baseline, 12 weeks, out to 6 months here for any of our indices of cardiovascular health. Again, disappointingly, we showed no effects of the exercise on any indicator of cardiovascular health in those with high-level spinal cord injury. So again, the same pattern, improvements in fitness, no improvements in cardiovascular health. What about combining these types of exercise? So this is now a type of exercise that we like to refer to as Apple. Oh, so just to confirm what was happening there, basically, this individual has a high-level spinal cord injury. He's actively using his arms to move the arm crank ergometer, and his legs are attached into the same crank. So by moving the arms, it passively exercises the legs. And we thought perhaps this is a way that we can improve blood coming back from the lower legs back up towards the heart and get a better effect. Again, we saw this increase in aerobic fitness following this time an 8-week intervention. But again, any index of cardiovascular health that we measured, no real change. So I guess, I could have selected many other types of exercise. To my knowledge and some of the recent reviews that we've done on this, really the pattern is the same. For those with higher level spinal cord injury, many of these interventions do a really good job of improving cardiorespiratory fitness. They come with many psychosocial benefits, there's community benefits, there's a whole range of benefits for the exercise. Specifically for cardiovascular health, it seems those interventions as designed are not working effectively for those with high-level spinal cord injury. Now, maybe this is just an effect on time. So next, what I'm going to share with you is some data that now takes a look at the longer term effects of maintaining high levels of physical activity or cardiovascular health for individuals with high-level spinal cord injury. So what we did in this study here is we used these accelerometers. We actually coupled them with GPS devices so we could see over a longer period of time how active and where individuals with high-level spinal cord injury were getting their activity. We then cross-sectionally looked to see whether those that are habitually more active have better cardiovascular health. And for the first time, whichever marker we chose this time, we saw really nice relationships. So what these figures show basically is that as the amount of moderate to vigorous physical activity per day increases, our measures here of cardiac function increase. And we showed this was the same, whether this was just the total minutes of physical activity, what was achieved in a wheelchair, or what was achieved through non-wheeled based activity. So some really nice relationships here, really showing for the first time that chronically, if you maintain higher levels of fitness as someone with a high level spinal cord injury, you can have benefits, or at least it seems there are associations with better cardiovascular health markers. Another way to look at this is also to say, well, what about if we compare, Paralympic athletes who train 16 to 20 hours a week, but have a high level spinal cord injury? What if we compare those trained individuals to individuals that live in the community that don't do that level of exercise training? And, Liz asked me the question ahead of time, is there any evidence that taking part in exercise can actually modulate or change autonomic function? One of the ways that we can assess autonomic function is through something we call a sit-up test. So this is a very straightforward concept. You would have an individual with spinal cord injury laying down on a table, and with some assistance, we would move you from the supine up to the seated position. And we do this while measuring beat by beat blood pressure. And this is typically the response that we see in individuals with cervical spinal cord injury. Your blood pressure might be here. You undergo this, what we call head up tilt, or this tilt, and blood pressure really starts to decline. And then we move back to the supine position and blood pressure comes back up again. And again, the reason this happens is because that part of the sympathetic nervous system isn't functioning as well as it should be. When we look at that change in blood pressure across a group of athletes versus non-athletes, there is a really stark difference here. So the non-athletes have this drop in blood pressure that exceeds what we would call a clinical cutoff for having this condition, which is called orthostatic hypotension. It's a direct measure of autonomic function. And so in the non-athletes, you see this big drop in blood pressure. In the athletes, they don't have anywhere near as significant drop in blood pressure. And so this is, I guess, some of the only evidence I'm aware of that actually, if you take part in exercise training, and again, these are individuals that were Paralympic athletes, they were very highly trained, and they had been Paralympic athletes for, on average, about 5 years in the study. But really some good evidence, again, that long-term exercise can actually change things not only about cardiovascular health, but also about autonomic function. This is again a similar study here. We ran just a different set of outcomes in this study, but same idea. We have our able-bodied groups, we have our SCI non-athletes, so cervical SCI non-athletes, cervical SCI athletes. And again, these are different measures of cardiovascular health. We saw the same pattern across all of these indices. That individual, the non-athletes, so here a higher value is worse, a lower value is better. This is looking at how well the heart functions and how the heart and blood vessels are coupled to one another. And what we see here in the non-athletes is you see an increase or a worsening of this function. In the athletes, again, it's much more close to what we would see in able-bodied individuals. Again, suggesting, like the last figure, that actually with long-term exercise training, even in those with high-level spinal cord injury, you can improve cardiovascular health. I'm going to finish on this slide, and this is kind of I guess a bit of a provocative, thought-provoking slide. And I'm sure many of you on this call will have heard of epidural stimulation or transcutaneous stimulation or neuromodulation happening in the field of spinal cord injury. And essentially what this refers to, if we focus on epidural stimulation, it's the one that's been most studied. And this is happening at Fraser in Louisville. Many people are being implanted with essentially what is a small electrode array placed in the lower thoracic or lumbar spinal cord area. And what this array essentially enables you to do is to create pulses to your spinal cord that would replicate what your brain would normally do. And you can program these stimulators to work in different ways. So you can target either improvements, or you can target, skeletal muscles, the abdominal muscles, the leg muscles, the arm muscles, or what we're finding is you can actually control the autonomic nervous system, so the heart and blood vessels. And you do this just by setting the stimulator array differently. So this brings up a really interesting point. If we now have a way that we can potentially reactivate that sympathetic nervous system, then perhaps if you were to be able to pair this type of technology with exercise training, then maybe you could expedite those effects in high-level spinal cord injury and get an exercise training effect more like what we see in low-level spinal cord injury. And so this is really the only study that I'm aware of that's done this. But essentially what they did, and it was a case study, is they took things like VO2 peak, that cardiorespiratory fitness, or stroke volume. And what they showed across two separate tests is with no stimulation on, is that this, this value is very reproducible. Just acutely turning the stimulator on increased the responsiveness of the cardiovascular system about 20 to 25%. Just acutely. This isn't an exercise training intervention. So this is just an acute response. So by using this type of technology, it seems we can now reactivate some of these circuits that are still present below the injury, just not functioning properly, and essentially, almost make them able to respond again appropriately during exercise. And so now what I think we're at a really interesting point in the field where there could be this idea of combining technology with exercise training to really expedite some of the responses that might otherwise take a long time to happen. So with that, I'll just bring together the talk and say that it does actually seem that individuals with high-level spinal cord injury are able to increase aerobic fitness following pretty much most forms of active exercise. The passive exercise, like the body weight supported treadmill training, doesn't seem to work too well, but certainly the active ones do. The responses to interventions lasting 8 weeks to 6 months suggest that for high-level spinal cord injury, that duration or volume of activity is actually probably insufficient to improve cardiovascular health. For low-level spinal cord injury, those interventions work really well. If we compare or do these comparative studies between individuals that have maintained high levels of activity for long periods of time, then these studies suggest that there is capacity, even amongst high-level spinal cord injury, for exercise to improve cardiovascular health and perhaps autonomic function. And then this final point, really, that perhaps we're at a point now in the field where applying some form of neuromodulation may be able to expedite some of these improvements to cardiovascular health following exercise training. So with that, I would just like to thank all the members of my lab that made all of this research possible. It was most of their hard work that did all of the research featuring here. And of course, the funding agencies as well that supported the work. And yeah, thanks so much to you for listening as well.
Sorry, I thought I unmuted. Thanks, Chris. Of course, because in Zoom, we can't have a Zoom meeting without someone failing to unmute. So we are going to go right into David's presentation, and I'm keeping track of all the questions, and so we're gonna go to the questions once David has completed his talk. And let me spotlight David. And there you go, sir.
Okay, slides up, audio. Someone give me a nod if we've got, all right, good to go. Okay, so this is perfect. Dr. West has warmed us up. So I'm just gonna carry on at the same pace here. And you are getting presentations from physiologists. So we'll be zooming in and out from the forest to the trees throughout this whole thing as we tend to do. But we'll start with the forest view and whittle our way down here. And so starting off, we're talking about the topic of metabolism. And I think we should all just take some time to think about this word. It's very difficult to define. If you start to think right now about the definition you would give it. A lot of things fall into the topic. I'll show my description after this. It might not be called the definition, but we should all appreciate that there's probably not a cell in the body that's not involved in a process that we could call metabolic. There's a lot of different things we're talking about here. And yet, if we want to design health-based interventions, we need to have outcomes. And so I'm going to talk a lot about concepts that involve metabolism. And every once in a while, there's going to be a health-related outcome. And just understand that that feature list of the health-related outcomes can never encompass all of what metabolism is. Okay, so this is my description of metabolism, and I'll just read it word for word here. To meet the energetic needs of life, metabolic fuels, or macronutrients, are introduced to our system through a single entry point, it's our mouth, whereby they must be transported widely to their cellular end fates of utilization or storage. Transport, utilization, and storage. We're going to be talking about those three things throughout this talk. The coordination of this complex system, a milieu of nested and ever specializing organs, tissues, cell types, is achieved via a distributed control system. In vertebrates, it follows that the brain is a player in this arena, but the role of the brain in certain metabolic processes is not self-evident, neither strategically nor phenomenologically. So at the end there, if you think about the phenomenological or like first-person lived experience of metabolism, you cannot will your pancreas to secrete insulin. There's so many of these metabolic processes, by definition, the autonomic nervous system, that we don't have volitional control over. So because of that, from the outside, it's not easy for us to understand these things. And then from the inside, it can also be very frustrating, right? But also strategically, you don't have to design a system this way. You could design it so that all the organs were completely decentralized and operated fully on their own. Like the pancreas can detect venous glucose in the hepatic portal vein and respond with an insulin secretion independent of the brain, but the brain can modulate it. Why? Right. And so we are vertebrates. We have a central control, a brain. And thank you, Dr. West, for introducing this topic, because normally this slide takes me like 10 minutes to go over. So we have on the right side, the parasympathetic sympathetic nervous system with the cranial sacral distribution. Cranial nerve 10 primarily does most of the detecting of what the autonomic different systems are doing. And then an effector response can be put through the sympathetic nervous system, especially in response to certain stressors that require immediate response. This output through the sympathetic nervous system, the pathway goes through the spine. And that's very important. And it goes through the spine with nerves that exit in between nerve roots in that kind of segmental orientation, like we've seen with the previous INSCI exam, and you're assigned a level maybe for your injury as well as a completeness. The sympathetic signals that are coming out are also coming out level by level like that. So the level of injury becomes very important there. And lots of different tissues are talked to by this. The blood vessels and the heart, yes, but the autonomics are going to a lot of different tissues. For example, fat cells, adipocytes, are innervated by efferents that come out, nerves that come out in the sympathetic system, and then centralized organs as well, like the visceral organs that are within our abdomen. And many of these responsible for metabolism, and in complex ways that involve what we would call like neuroendocrine signaling. So a nervous signal that's turned into a chemical signal that's turned back into a neurological signal. And so just keep in mind how complicated this is and how the level of injury really matters. So if we go from now metabolism, this really big picture idea that has to do with transport, utilization, and storage of energy, to what cardiometabolic disease is. Cardiometabolic disease is a measurable, defined thing. It's quite concrete. And the word cardio is in there for a reason. So a clustering of risk factors related to metabolic function with strong implications for cardiovascular health. This is my definition. And what we're going to do is go through the risk factors and define them, and then talk about the effect of exercise on those risk factors. So when we say strong implications for cardiovascular health, in the end, it's usually not dysmetabolism per se that results in mortality. It's some type of cardiovascular outcome. So to put it bluntly, people don't die of diabetes, they die of a heart attack due to diabetes, or the effect of diabetes on the cardiovascular system. So we'll start with identification, and we're just going to describe the risk factors right now for cardiometabolic disease, and then we'll talk about exercise. Okay, all of this comes from a document published by a group of people that was put forth due to the Consortium of Spinal Cord Medicine, Paralyzed Veterans of America initiative for what they call clinical practice guidelines, or CPGs. There are 11 of these, and these CPGs are for cardiometabolic disease. So the fact that there's 11 of these, I mean, just for the PM&R docs in the audience, the amount of knowledge required to treat spinal cord injury is just, it's overwhelming. It's amazing. So just thank you to those care providers. So if we are going to dive into these documents and we can provide them, and on the right, we'll zoom in on that table. This is table 3. And then if we look at how this works, so I'll orient your attention a little bit right here. Cardiometabolic disease is any 3 or more of the risk factors below. So it doesn't matter which, as long as you have 3 or more, you can be diagnosed with cardiovascular disease. Okay, what are the component risks? 1 would be impaired fasting glucose, or prediabetes, or a stark diagnosis of diabetes. So sometimes the language here is funny, but it's very useful for clinicians. If someone comes in with a diagnosis of diabetes, then you get to just check this box without testing them. And if they don't, then you give them a test. What test would you give them? It's either fasted blood glucose, P here for plasma, an oral glucose tolerance test, or their glycosylated hemoglobin levels. You have obesity and dyslipidemia, 2 components of the dysregulation of fat metabolism. And then you have hypertension, which involves the cardiovascular system, which is very complicated based on level of injury. You can have people that are hypotensive. They have high levels of injury, just like Dr. West explained. And thank you for covering that, Dr. West. So I will focus mostly on the things that have to do with obesity or the stored fat, dyslipidemia, sugar, and dyslipidemia, fats, and dysglycemia, sugar. Okay, so these are the criteria, but normatively, what does the distribution look like if you actually measure this in people with spinal cord injuries? It's a brilliant study from 2014 where these different component risks are broken down here. So within some of these, there's multiple levels of measurements you can have. So you have a category, and then you have health-related outcomes in that category. So body mass index is one way to quantify obesity. Obesity is the risk factor, right? Low density lipoprotein cholesterols is one component of dyslipidemia, right, which is a risk factor. And so you have this in paraplegia, the dark bar, in tetraplegia, the gray bar, and the relative distribution of the population of these different outcomes. Okay, if we just start right here, if you go 3 or more in tetraplegia, you get over 60% of the population who are cardiometabolic disease diagnosed just off the bat, which is amazing to think about. And then if you just zoom out a little bit here and start to look at those different categories I was talking about, if we think about the transport, utilization, and storage of chemical fuel sources, and we break them down broadly into the fats and the sugars. Here in spinal cord injury, I blanked out the things related to the topic that Dr. West graciously covered. There is more of a problem of fat metabolism. That's a broad view of my broad view of the problem. And so I would just like to establish that and put that part forth. Okay, and then we have certain risk factors that have caveats. So especially if there's any clinicians in the room, body mass index, there is a spinal cord injury population specific cutoff. What is body mass index? It's the ratio of height to weight. Right? And then there's a little bit of math to try and make those things into a number that's like, comprehensible to a human brain. And so within the body weight or the mass, you don't have the composition or how much of that is made of different things. And in the context of obesity, we want how much is not fat and how much is fat, essentially. If you do this and you make it relative, you can have body fat percentage. And so in people with spinal cord injuries, the BMI cutoff is much lower than in people without spinal cord injuries. Why? For a given amount of lean tissue, you have proportionally more fat tissue. And that could be because below the level of injury, there's less lean tissue. It could just be due to the atrophy of the paralyzed muscles, right? It's due to more. It's also due to infiltration of fat into the paralyzed tissues. And so I can tell you, doing whole body scans where you can break these things down, there's people I've scanned that are 23 kilogram per meter squared tetraplegia and over 40% body fat, which we would consider morbid obesity in the general population. And so from the outside, in terms of obesity with spinal cord injury, this is a risk factor caveat. What you see is not what you get in terms of fat mass, right? So people are going to be what I described as essentially marbled from the outside in when it comes to fatty infiltration into the tissues. And then with fasted blood glucose. So how did we get that diabetes diagnosis or the dysglycemia? Fasted blood glucose. There's a study in 2007 and multiple other studies that corroborate this, showing that especially in people with high injuries, you get a fasted glucose. In this study, over 30 participants, fasted blood glucose, 0 had a diabetes diagnosis, oral glucose tolerance test. So they were given a sugar drink the blood and the sugar goes up and then back down as the sugar enters the blood and then enters the tissues. 94% were diagnosed based on OGTT. So the take home from that is you have to perturb to see pathology. So if you're going in and you're seeing your doctor, right, you can bring these things up to them. And if you are one of those physicians, now you're equipped with a little bit of this information. Okay, so that is the how to diagnose cardiometabolic disease. There's 5 component risks, right? Within each of those risks, there's multiple health outcomes that can be used. And there's a brilliant document that outlines all of this, all right? You all have access to it, great. Okay, so now can exercise modify these things? That's the question we're gonna ask. So we go back to the same document and we go to table 5 instead of table 3. You can see that in terms of managing cardiometabolic disease, the primary management strategies put forth are nutritional and exercise. We'll focus on exercise, but at the end of this presentation, we're going to be forced to wrap back around in nutrition. And what does this document put forth? This is a clinical practice guideline, right? This is what you should go by if you're a clinician. It's a recommendation from the PVA and the Consortium for Spinal Cord Medicine is 150 minutes per week of moderate intensity physical exercise. You should begin that as soon as possible, post-injury, right? And you can break that up into different chunks, basically. And it should be at least 30 minutes per day, right? So you can't just do all 150 on one day and that counts for your whole week. It's basically at least in the general population, to account for the phenomena of golfing, where you can say that you've done exercise for 5 hours in one day and that covers the whole week. And then secondarily, there's pharmacological treatments for each of these component risks separately. And I think that's important. And that's how we're going to break it down for exercise as well. But for example, dyslipidemia, especially high low density lipoprotein cholesterols, very well known, most prescribed drug in the world to manage this. But certain other component risks are not managed pharmacologically, like obesity or increased fat mass. There's no pharmacological intervention for this right now that's widely accepted. And only recently have things like diabetes been managed this way. So each of these has a different kind of management strategy pharmacologically, but in terms of exercise, there's this kind of blanket catch-all statement, right? And we're going to challenge that a little bit. For overall cardiometabolic disease, this is another authoritative guideline. This guideline was evidence-based, extensive literature review. Dr. West can tell you about it. He's one of the co-authors on it. And this method called Agree-2 of combining evidence-based to develop a guideline did conclude with moderate to high confidence that exercise can benefit cardiometabolic disease in people with spinal cord injuries overall. So for overall cardiometabolic disease, moderate to high confidence. So you should definitely go and exercise if you have a spinal cord injury and you want to use exercise to treat your metabolic disease. But there's other evidence that within the individual risk factors, like pharmacologically, how they're targeted individually, that there's certain areas where exercise excels and certain areas where exercise is limited. So that's what we're going to get into for the specific CMD risk factors. We're going to break it down. And is it the fact that exercise is just always good, or is it a little bit more nuanced? So these are the 4 risk factors as we've discussed them, right? Obesity, if you want to target that, you would use as many calories as possible. The first law of thermodynamics does apply to biological systems. A calorie is a unit of heat measurement. We're going to go into that in a second. And so if you want to reduce the total mass of the system, you have to expend more calories than are being put into the system. Dyslipidemia, you would want to utilize fats as a fuel source. Dysglycemia, you would want to utilize sugars as a fuel source. And then hypokinesis is what Dr. West covered. And you have to have a way to transport all of these things around the body in order to utilize them. Okay, we're going to focus on use. Exercise doesn't only result in utilization. Also, if you have a fuel source that's stored and you mobilize it, you have to transport it somewhere to use it maybe. So keep in mind, this is all a complicated system, but we'll focus on use. And what do we mean by use? So it's technically the combustion of a hydrocarbon, or in the sense of our system, the oxidation of a macronutrient. Oxidize a fat as a fuel source. That results in the expenditure of energy. So both the total energy being expended and the source are both important components. And in the end, we call that burning calories. Burn comes from the concept of combustion. And technically at the chemical level, we combust these hydrocarbons, but it happens in an aqueous environment, so we don't catch on fire, but it does produce heat. Okay, so now we'll go through, we have obesity, dysglycemia, dyslipidemia, and then the hypokinesis, which was already covered. And we'll start with obesity. And so I've published this paper recently. You can go and check it out. And we go through some simple math in this paper to show the limitations of exercise in people with spinal cord injuries to just simply burn a lot of calories. And Dr. West started to hint at this, right? And if you throw volume at this problem, you can solve it in spinal cord injury. But here's some math to show how that works out, right? Keeping in mind that Dr. West's previous example with the athletes, these were professional, semi-professional, not sure with the Olympics now how it works, athletes, right? Their goal was to not treat their cardiometabolic disease. It was to participate in athletics. But okay, someone without a spinal cord injury, conducting standard exercise. By standard, I just mean something I could probably do if I left my office right now. I will expend between 10 to 20 calories per minute at maximal exertion. So kcals, it's a unit of heat, right? And we're used to seeing that in food. Food is assigned a certain potential calorie potential. And if we then take that in and expend it, we do so at a rate almost always. And so 10 to 20 kcals per minute would be me at maximum. I might be able to sustain this maximum for 3 to 5 minutes. And so in the end, I'm not getting a lot of calories burned. In people with spinal cord injuries across all exercise modalities, including modes you can probably access now and other ones you might not have access to, like fancy electrical stimulators, like FES bikes that cost more than my vehicle, right? Across a lot of different modes, you're going to get this 5 to 10 kcal. So blunted maximum. In terms of the sustainable energy expenditure that's possible, if I go and I ride my bicycle, like I will on the way to get home, I will be at about 10 kcals per minute on my ride home. Me riding my bike, listening to music in my headphones. If someone with a spinal cord injury does sustainable exercise, and this is from that paper I showed previously, we provide citations. I will show you some of this data directly. Sustainable exercise is going to be somewhere between 2.2 and 2.4 kcals per minute. That's from the data that I'll actually show you right now. And so just look at the difference in the sustainable rate. And if we just do the maths on this, so the CDC, Center for Disease Control in the States, will have a weekly target for people without spinal cord injuries, how many kcals they should try and burn for the general health benefits of exercise, between 1,000 and 2,000 kcals per week. Let's take the lower end of that total weekly target and the higher end, 4 kcals per minute, of the spinal cord injury. And if we go 1,000 kcal target at 4 kcals per minute, we're going to get to 250 minutes of exercise per week, just over 4 hours. If I do that 5 days a week, it's about an hour a day. Keep in mind, this is already 100 minutes more than the guidelines tell me to do. If I take the other situation where I'm going for 2,000 kcals per minute and I'm at the lowest rate, right, we're getting to over 16 hours of exercise per week required to hit this target at that kcal expenditure rate. It's just not plausible. If you go 5 days a week, that's 3 hours and 15 minutes per day. And that's not even the setup to get in and out of the exercise equipment, right? And so there's just a volume problem here. And I don't want to discourage you. Your body is responding. Your body is dynamically coupled to the environment and the demands you're putting on it. You will feel exertion, and your physiology is coupled to that exertion. It's just that there's a ceiling problem here. So this is another study from my dissertation showing the relative, this is percent, and Dr. West introduced us to the concept of VO2, whole body rate of energy expenditure, as well as RER, which is related to which of those two fuels are being used, fats in this direction, down, and sugars in the up direction. This is exercise that was undulating, so high intensity interval training. There's intervals, that's the gray bars indicate the work periods. And you can see people with paraplegia dynamically coupled. The relative response of the physiology is really nice, but there's just a peak problem that happens here. So if you're just adding up calories to get to the obesity target, it's going to be really different. Okay, we'll move on to the other two components now. Do you want to be not just burn calories, but from what sources do you want them to come? This story, it depends on the mode. The mode is very important. By mode, I mean the type of exercise. So previously, I was kind of lumping all of exercise into one thing because in the end, a calorie is a calorie. But to target certain sources of calorie expenditure, you want to do different types of exercise. So this is a circuit that we have developed, and you basically alternate between some really low resistance, really high intensity high speed arm cycling that's supposed to be not that intense. And then you go between the arm cycling and multiple upper extremity resistance lifts. This person has a mask on their face, so this is how you know we can measure the calorie expenditure and the source of the calories. Okay, you go through this circuit, takes about 45 minutes. You end up doing 3 sets of 10 reps of 6 different upper extremity lifts and 20 minutes of arm cycling, all within 45 minutes, 42 and a half if you do it correctly. It's really intense. It requires a little bit of help. It requires some specialized equipment, although this equipment isn't super specialized. And if you do that, so another paper, now we'll zoom into that figure and I'll orient you to this figure right here. We have total energy expenditure on the tall axis, right? If you look at black and white on the top, you have the energy that's coming from carbohydrates, those are the sugars, or from lipids, those are the fats. So the total is the two summed up. And at all times, at rest especially, we're using both fuel sources. You have both in a control condition and with circuit resistance exercise. In people with paraplegia, that's the B, and with tetraplegia, that's the C. You have during and then after exercise. So during exercise, again, the peak rate here, 4 kcals per minute. They're doing a really intense circuit. Me riding my bike home, I'll probably be at 10 kcals per minute just commuting, right? So let's just appreciate this peak value. It's not very high, but look at their response after exercise. During as well, they switched over to almost entirely carbohydrate utilization. So that's their metabolism responding. And then afterwards, for over 2 hours, you have this shift. So even their resting metabolism is increased and more of it is coming from fat. So there's a relative transition toward preferential fat utilization at rest during recovery from exercise. And that also happened in people with tetraplegia. And that was against our hypothesis. We thought that these people with tetraplegia would not have this shift. But at 2 hours post-exercise, they both have statistically, that's what's denoted up here, an increase in total energy expenditure and the energy coming from fat. Okay, now we'll compare the circuit to other modes of exercise. Different papers, same graph, you've already been oriented toward this, but down here you have the high intensity interval training, circuit resistance training. Those are 2 different forms of high intensity training. And then you have a moderate intensity continuous arm cycling, which is the MICT here. And we can look at during exercise, all of these pretty low total energy expenditure, pretty similar, even though they feel much different, right? So you have the ceiling problem, but after exercise in terms of the recovery, you have a metabolic response that is distinct and is preferencing the high intensity exercise in terms of shifting the types of fuels that are being used, right? So you are responding, right? Your body is coupled, but there's this ceiling problem. So is exercise always good? And then we'll outline all of these. So for obesity, it's a big ask. Unless you have a lot of time and you are not worried about overuse injuries, I would say that exercise alone is not a good solution for obesity. For dyslipidemia, so far the data looks like it's mode specific. You have to do a certain type of exercise to get the fat utilization. For dysglycemia, so that's the blood sugars, it looks like most likely if you do exercise, you'll be benefited here. And Dr. West went over the hypokinesis. So the problem is not if you're responding, but how much. And as Dr. West introduced, the solution might be not to get you to respond, but to take the response you have and pull it up a little bit. So a spinal cord injury is not denervation. You have the ability to send the signals. They're just not getting through from the top. So if you can stimulate that dormant autonomic nervous system and just augment the gain of the response, you've probably got something. And then this is like last slide. So I just want to end with like exercise is necessary, but not sufficient. So you have to couple this with the nutritional approach, right? And it might be something like exercise is good for the utilization, nutrition is good for the storage, something like this, right? That's going to be like easy take home kind of cliche, but it has to be coupled with nutrition. It's often said that you cannot use exercise to outdo an imprudent diet. If that's the case in me, it is surely the case in someone with a spinal cord injury. And also your exercise goals should be for diverse reasons. So I am always just urging people to try and tap into states of psychological flow. You should exercise for self-efficacy. I wrote collective embodiment here. I guess that's my hipster term for teamwork. I love that with spinal cord injury and exercise, there's often teamwork involved. You should exercise for a bunch of reasons, but keep in mind for your cardiometabolic health, there's going to be certain components that you can't get with just exercise unless you have tons and tons of time. So that's the end of it. I'm right at 25 minutes. That's good. And I guess now we open the floor.
Thanks, David. So let me remove your spotlight right now. Okay. And we do have a number of questions. I want to I want to try to organize real fast what I heard you say, David, since you were the last person to speak. And that is that you, in the literature that I read that I believe you were an author of, there were two, I believe, more effective types of arranging exercise. And one was the HIIT, high intensity interval training. And the other was that circuit resistance training. I wonder if you could just say a little bit, tell me if I'm accurate about that, and say a little bit more about how those are structured for people with spinal cord injury, and if it's different for high level injuries or lower level injuries.
Yeah, absolutely. There are single studies, and then there are approaches that combine lots of single studies. So the best source on this topic of what type of exercise is good for what outcome metabolically is going to be a paper published by Matthew Farrow as part of his PhD dissertation. It's a group in the United Kingdom. And they do a beautiful job. And there's a really nice table in there of just showing this is the evidence for that outcome, right? So was in the study you're talking about with me, like I just picked two types and I compared them. So those aren't necessarily the best, but within those types that I compared, we can start to draw some conclusions. So for the circuit, we have, and I published a methods paper. I showed a picture from it with that gentleman, John Luigi, and he signed a media release, and he's doing the different workouts. So if you go into that paper, it'll tell you exactly how to do this thing. So, and there's a question in here from Chris, like transition between different lifts, minimal time. That's the key there. So difference between high and low injury. Yes. Hand function does influence your transition period. So we structure the circuit differently if you have or do not have hand function, so that we can minimize transition time. Because with this type of exercise, it's both the stimulus itself and the lack of recovery that accumulate that make it so that it's metabolically difficult, and it feels difficult as well. Like the first time through the circuit, you're like, oh, that wasn't so bad. And then halfway through the second round, you're like, oh no. And then by the third one, it's all added up. No one's doing a fourth, like maybe someone is, but yeah. So the structure is really important. That's in that paper. I can share that with anyone. If anyone has any questions about that, I'd be happy to walk them through it. It really helps to have a friend there to help you. So when I say like teamwork, like to do the circuit alone, it's possible. But it really helps to have someone to be able to set the equipment up for you so you can get the transition time super low, so that all you're thinking about is the next lift. So I'll say that. So for the high intensity interval training, you can use any rhythmic modality to do intervals. We had arm cycling here, and that's just like standard desktop arm cycle where it looks like a, bike crank essentially. You could have something like a glider. You can program an FES bike to do intervals. You can have some type of combined upper and lower extremity movement like Dr. West showed. So there's a lot of ways you can do intervals. With intervals, the important thing is that there's a work period and a recovery period, and you just alternate those. And you don't do them just once, you do them multiple times. And in general, the more intense the work is, the longer the recovery period is, and vice versa. They kind of have this inverse relationship.
So just to be clear, high intensity interval might be working on an arm crank, and you work very hard for a minute, and then you slow it down for a minute, and you work very hard for a minute, slow it down for a minute, and maybe even take a break. That's that kind of thing, doing cardiovascular exercise. And the resistance training was that you alternated from low weight, high rep resistance, like a chest press or a row or a lat pull, and cardiovascular exercise. You went back and forth amongst those.
Yeah, importantly with the circuit, and this is designed for a metabolic reason, you can actually see, like in the data I showed, the recovery with the, let's call it cardio movement, is supposed to be low resistance, high speed. The lift itself should actually be a slower speed in terms of the contraction and a more moderate resistance. So spinning in between the lifts should be super fast and easy, but the lifts themselves, there should be tension involved. And especially on the return phase from the lift, you should go slow.
So let me go back to some questions about Chris, when Chris was speaking. I'm not going to say that I totally understand these questions. Can we require significant structural intervention, fusion, et cetera, without having major spinal cord injury? I do not understand that question. If you all do, Chris,
Yeah,
if you understand it, answer away.
if you're referring to like spinal fusion, then yes, you can absolutely have spinal fusion, which just involves essentially connecting together two of your vertebrae to reduce movement between those two vertebrae. So that could be warranted for a number of reasons to correct things such as scoliosis or spine deformities. And yeah, that can be done without any injury to the spinal cord happening. Of course, most people that have a spinal cord injury also require some form of spinal fusion as well, but the two aren't the same thing. So I'm not sure if that was what the question was relating to, but it sounds like it was. So if not, happy to adapt the answer as necessary.
Well, if I mess that up, whoever asked it, if you want to chime in and say that what you really meant, then feel free right now. Okay, so let me go. So the next one was, Chris, with your studies, were the injuries, did you have information about the level of completeness? Were they complete, incomplete, tetraplegia, or even paraplegia?
Yeah, so in all of the studies that I was part of, at least, every time we included someone with a cervical spinal cord injury or tetraplegic, they were motor complete. So if anybody is familiar with the American Spinal Injuries Association grading for spinal cord injury, they would have been an Asia A or B, and in most cases an Asia A. Now, just to clarify for everybody, just because somebody is graded as an A or B, again, as for that first kind of slide I showed, it doesn't actually mean anything for integrity of the autonomic nervous system. So how intact the nervous system is, between how intact the motor and sensory systems are, those three do not necessarily go hand in hand. We have tried more recently to specifically separate our samples based on those with autonomic intact or autonomic complete injuries, but we end up running into a problem of what we call power, and that is having, enough people in our study samples that we can adequately split by autonomic complete, motor, sensory incomplete, and then autonomic incomplete, motor incomplete, sensory complete. You end up with so many different stratifications that you need to make that it becomes really challenging to be able to draw any conclusions from those studies. So yeah, they were motor complete in those studies, but not necessarily autonomically complete.
Here's another question, Chris. Does the athlete study show change, or does it show that people with orthostatic hypotension don't become Paralympians?
That is, of course, a very astute observation and possibility. It is entirely possible, and this is something that we have wrestled with for quite a while when studying the Paralympic athletes, is, is someone with a cervical spinal cord injury who happens to have sparing in their sympathetic nervous system, that means, functionally connected between the brainstem and the sympathetic nervous system, are they more likely to become a Paralympic athlete because they have better autonomic function? Maybe. We do not have a good way to be able to answer that on a large enough scale. My hunch is that depending on the Paralympic sport that one takes part in, that may be more preferential than another. So for example, I have done a fair amount of work with paracycling, and that is a very individualized sport that is, can be conducted over reasonably long distances. And we found that people that came first, second, third, and fourth in the world championships all had sparing in their sympathetic nervous system. The people that came places 6 through 10 did not. So in some of those sports, it definitely seems that there might be this idea that those that have sparing are more set up for success than those that don't. And this is why we've been trying to incorporate some form. This isn't just me, my postdoc supervisor who I worked with has been very passionate about this as well, Andrei Krasikov, about trying to incorporate autonomic testing or screening into classification for athletes. Now, with the studies where I did that comparison, that was mostly done in the sport of wheelchair rugby. And there, I think it's a little harder to make the argument that those that would excel at wheelchair rugby are those that have sparing in their autonomic nervous system. You know, that's a team-based sport, and there are many other things that come into wheelchair rugby performance above and beyond that. So that's a really long-winded way of saying absolutely, it's a possibility that it's not cause and effect. It's certainly not cause and effect. And, you know, very rarely in science can we ever truly assign cause and effect to these type of studies. But certainly, and not just on the orthostatic hypotension, but some of the other data that we now have on the other indices, I think is starting to paint a picture around some of the benefits really, again, on this idea of like longer term volume of exercise being a way to improve cardiovascular health.
So just because they may have had some autonomic sparing and therefore were, you know, getting a gold medal and not coming in 10th, doesn't mean that someone who came in 10th or 15th didn't improve their cardiovascular health, which is what we're all after. I mean, some of us might be after a gold medal, but
yeah, maybe I can do this. So I've still got my, maybe I don't have it. No, I was just going to see if this is quite a nice way, because I thought this question might come up, but I have yeah. Can everyone see this slide?
Yes.
yes.
Okay, I'm not going to show it in presenter mode. I'm going to show it. This is one of my previous postdoc supervisors' favorite slides to share. And this is this idea of, you know, when you're talking about motor and sensory completeness versus autonomic completeness, it's really like comparing apples and pears, like the two are different. And so this really comes down, and the reason it's so different is because if you take a cross section through the spinal cord, and you look at where, so in our spinal cord, you know, imagine this as, you know, kind of your information highway, and imagine your highway as having different lanes. And now each different lane in this instance controls different functions. And what you can see on this next slide is if we look at these different lanes or highways, some I've highlighted here, or some have been highlighted in red and yellow. These would be where the highways with the information controlling motor function comes from. Here's the ones which contain sensory function. And here's the ones that contain autonomic function. And so what you can see is that all three of these motor, sensory, and autonomic pathways are located in different areas of the spinal cord. So what it really comes down to is on an individual level, like how did any one specific spinal cord injury manifest over those first few weeks, and which tissue did it interrupt the signals between? It's extremely rare to have a true, you know, anatomical transectional cut through the spinal cord. It's much more likely that you will have patches of the spinal cord that are intact. And really, it just comes down to, you know, almost a little bit of luck as to where those patches of the intact tissue is. And so this is why these three functions don't line up with one another particularly well. And as we appreciate more and more about autonomic function, there is a push to have these types of assessments included into clinical classification, as well as things like sports classification. And so again, postdoc supervisor Andrei Krasikov, he has now put forward standards for quantifying autonomic function as part of the clinical classification for spinal cord injury. So I think we're moving in the right direction. We've got a long way to go. And until we get there, there are always going to be these scenarios in many of these studies where people will assess motor and sensory completeness, but not autonomic completeness. And so interpreting the studies becomes challenging in that context. So I don't know if that helped to answer the question, but.
Well, that led to another question, which is does a test exist to easily determine autonomic function or dysfunction?
Well, I've spent about 10 years trying to answer exactly that question, and we have tried many different forms of tests for sweating, for electrophysiology, for tilt testing, for looking at dysreflexia severity. And honestly, the one that I've come back to time and time again that seems to be the most straightforward to do is to ask somebody with spinal cord injury to exercise and simply measure the heart rate response to exercise. If the heart rate is able to go over 130 beats per minute, we would suggest that there are sparing in that part of the sympathetic nervous system. If it sits around 110, 120 max, which it often does in people with cervical spinal cord injury, we would suggest that, there is not sparing in that nervous system. But of course, this does require the fact that the person you are testing has sufficient arm function to be able to perform the exercise test to try it out. Without doing some form of exercise test, it becomes really complicated to try and determine autonomic completeness, because there's so many other things that will determine how your body responds. So, even just take that straightforward tilt test, for example, that the response to that is also dependent on hydration, electrolyte balance, many other things as well, not just the integrity of the nervous system. So no straightforward test, but that's probably the easiest one. And it can be done with a heart rate monitor, essentially, which is relatively low cost considering, the clinical cost of many of these other tests.
And how long do you have them exercise?
Depends on the type of exercise. You can achieve that. You can understand that within 5 minutes easily. So if you just do a continuously incrementing test, you make it harder and harder every minute or 30 seconds, the heart rate will respond very quickly if it's able to, usually within 2 or 3 minutes. So 5 minutes of doing that kind of gradually increasing intensity would be more than enough to be able to answer that question.
Okay, let me go back to my list.
Hey, Jenny, as long as we're here, because this topic really touches on multiple things here. So I have a question for Chris. Chris, if I gave you all of the data in the model systems, and then how many people enrolled into the model systems database became athletes, do you think there's something about their autonomic function immediately post-injury or leading up to their participation in athleticism that could help you understand if it's just the autonomically spared that are entering athletics or not?
Well, that would be a super interesting endeavor. I don't know. I mean, I guess entry into the model systems requires an exercise test at some point into the model systems.
Not mandatory, but it does happen.
Yeah. So I think if you were to isolate the ones where that had happened, we would be able to answer that question. If you had that, a baseline seeded blood pressure, I think they would be the two things you would look out for as being able to determine it.
Baseline seated blood pressure. And so you're not picturing, I'm guessing about the model systems database, anything else really in there that would help you?
Purely from understanding that relationship between autonomic function and, yeah, I mean, I don't know, things like, yeah, the autonomic dysreflexia and orthostatic hypotension data is not as straightforward as you may think. The two don't go hand in hand. Many people that have autonomic dysreflexia don't have orthostatic hypotension and vice versa. So, and when you get into bowel, bladder, sexual function, which are the other autonomic disturbances, that's controlled by a completely different circuit yet again. So, so I'm not entirely sure that helps either. So if I was to hang my hat on any two, it would be those two that I would probably look at first.
I think that's an important observation just from an evolutionary standpoint. Model systems database has been around for a while. And if there was a readily accessible autonomic assessment, it would have, I think, found its way into the outcomes. I'll say this, Jenny, and Chris is hinting at it. I have done some ridiculous things to try and assess autonomic function. I have pointed optical and thermal cameras at people streaming over 2 gigs per second of data, trying to elicit autonomic responses and not been able to pick up on something that's reproducible, that we think would be generalizable or in any way feasible. Because this is like, multi-$100,000 camera setup that we're talking about. It is very difficult to get at the thing that we're getting at. So we're trying, but this is just, really not, this is a complicated system we're pointing at. I think it is very clear from the community perspective, like what the information being communicated toward us, that this is so important. All of the things empirically that are ranked as, desiring return to function if you're missing them, are high up there, right? After dexterity, you're talking about a lot of autonomic things. But it is just not easy. So
I have another question on a different topic, and that is, I don't know if this was with regard to Chris or David's talk, but I think this was from Chris Lanham. With the disparity between males and females with spinal cord injury, did the studies on fat mass compensate for those sex differences? And if not, could shifts in hormone levels in spinal cord injured males after injury exacerbate some of the shift in body composition?
So the answer to both of those is yes, and I'm pretty sure yes. So there is a wild sex dichotomy here, right? Especially traumatic spinal cord injury. It's like 79.6% male in 2021 based on the UAB National Statistical Center database. And that tracks pretty well across multiple countries even. And so because of that, we have less women to study, right? If we learned one thing from COVID, it's that if everyone gets a condition, we can study it really quickly, right? That was at least a serendipitous thing that we learned from that. So if not a lot of people get the condition, we don't learn about it that quickly. But we do have enough data to understand just the body mass index component of the sex difference in spinal cord injury. And those tend to pretty much track with what we see in the general population. In men, so the second part of the question, definitely there is low testosterone, if that's the hormone you're referring to, other androgynous hormones as well. They come down. So this accounts partially, although not totally, for the decrease in sperm viability in men and the changes in male fertility that aren't seen in female fertility with spinal cord injury, but also other things. So does this contribute to that fatty infiltration that we talked about? Does this contribute in men, specifically the low testosterone, to all of the changes in fat mass that we see? That's a great question. I don't know if there's been a study that just correlates testosterone and let's just say like percent body fat. I don't know. It might exist. My colleague knows, Dr. Gary Farkas, like the world's leading expert on this topic. So I can get back to you on that one. But right now, nothing pops to mind for me. So.
Well, David, in some of the literature you gave me, I read a recent trial in spinal cord injury showed that testosterone combined with FES resistance training resulted in a 221 to 250 kcal a day increase in basal energy expenditure. How significant is that?
Oh, the 200 kcal per day? That is substantial.
Yeah. So.
Oh yeah.
I don't know if there is a standard of care that includes testosterone for men with spinal cord injury. I have no idea.
Yeah, I mean, if there's any physicians here, I believe the answer to that is no, in terms of standard of care. I do think that men could request it, and I do think that their physicians would probably work with them on that one. It can be referred to an endocrinologist.
I didn't hear. What was the question?
It was about, there was a recent study that showed that testosterone combined with FES resistance training significantly increased energy expenditure. And so my question was whether there was any standard of care these days that included giving testosterone to
Yes.
men with spinal cord injury.
Yes, but only those who we tested. We test vitamin D, calcium, and testosterone in our spinal cord patients. And those who would report, actually, I think one of the research that they're doing here is spinal cord patients who have low testosterone. So yes, and we refer them to endocrinology to be treated for, and then along with calcium, vitamin D, and all that. So yes.
Fascinating.
There you go.
I have to go, but thank you very much to both of you. This was excellent, and the level was also very good.
Great.
You guys were talking everything, and so this is very good. I have one question. I'm sure you know Dr. And Rachel Mergina, Dr. Gormy, Ashraf, who did research with electrical stimulation using quadriceps to show MRI decrease of fat mass. And his theory is that in order to exercise for spinal cord patients, particularly head tetraplegics and complete, you need those big muscles to have reduction in fat mass. Do you have anything related what you guys talked about applied to how do we fit this, that it was not replicated. I haven't seen that replicated anywhere else. It was just few studies that he published. Have you guys thought about that?
I absolutely have. I would guess they're part of the replication. The lack of that would just be due to lack of resources in order to administer that exercise and then have those outcomes at certain centers. Looking at that approach, it's a pretty unique electrical stimulation approach that lab uses, and you might need some specialized equipment. There's actual resistance involved in the contraction of the muscle, as opposed to something like an FES bike, right? An FES bike, your legs are powering the bike due to the electrical stimulation, but the bike isn't providing a large amount of resistance. It provides some, but not like how the Gorgie lab sets it up. And I would say that, yes, in terms of burning more calories, like Liz was just saying, like with the 200 kcal per day increase in the resting energy expenditure, that a change in muscle mass can help with that. It can facilitate that for sure. Whether or not the change in the muscle and the change in the fat are, coupled, like Dr. Castillo, you're implying, like if changing one is required to change the other, I'm not sure. I would guess at the level of the muscle itself with that fat that goes into the muscle. Yes, I would bet. But with something like visceral fat that might have a little bit more relation to like metabolic health, like globally, like stuff floating around in the blood. I'm not sure.
I think, and this goes to Chris too. If you use an upper extremity only, conditioning, but not using FES bikes, not exercising lower extremities, it has to be everything, and it's very difficult for our patients to have both. So we do train them, but you have to have both upper extremity and lower extremity, otherwise you're not gonna get the full benefit, don't you think?
Yeah, but I think it's not just activating the muscles as well. Like, using the FES to activate the muscles is not going to still give you the activation of the nervous system that I think we desire over the longer period of time in the higher level of injuries. There's been a few studies that have looked at FES as a way to augment blood flow back to the heart to try and improve things like cardiac output during exercise. But again, the long-term effects of that, it doesn't come through from FES interventions. It's only an acute response, and it's a volume loading response to the heart, which is not what I think we need from a cardiovascular health perspective. So I'm not talking about local muscle effects or, change in fiber type in muscles or fat accumulation in muscle. I think they're different questions, and maybe we need different modalities to achieve those two different things. But purely from a cardiovascular health perspective, the long-term data that I'm aware of in FES doesn't show any more benefits than, a combined arm versus passive leg exercise, for example.
Chris, wasn't
Agreed.
there a study that showed doing leg functional electrical stimulation along with volitional arm exercise? So if you're on the FES bike and you're exercising with your arms, doesn't that show an advantage over just doing, say, arm crank exercise alone?
It does, but again, just to be clear, it only does from the acute response. So when you just look at the acute response to exercise, it shows a elevated, VO2 value, that VO2 peak value we would look at. That does go up with that type of exercise, absolutely. I'm not aware of a study in the long term that's shown a benefit on cardiovascular health above any other. The only other FES studies that I know of were a case series that were published in Spinal Cord from Robin Gibbons, who did combined FES on the lower limbs, active arm, but during FES rowing, and looked in a series of cases as to what effect that had on the heart. But again, it was very difficult with such small sample sizes to really pull any of the long-term data out of that. So absolutely, is it better from increasing fitness or having a higher VO2 response during exercise? Yes, I think the evidence suggests that. But over the chronic period, again, from a cardiovascular health perspective, I'm not aware within that kind of 8-week to 6-month intervention point that there's been any further benefits for the inclusion of FES from a cardiovascular health outcome.
Okay.
David, I'm not sure if you have anything on that we're trying to think back to the Skya chapter, anything that we just came across, but yeah.
Well, I'm gonna have several questions about practical applications of exercise interventions. But first, I want to ask a question that just came through on the chat, which is, how does electrophysiology correlate to spinal cord injury? Is the probability of supraventricular tachycardia increased with spinal cord injury?
Yes, is the short answer to that. There has been in fact, of any of the areas that's been studied the most, it probably looking at arrhythmias in the setting of acute spinal cord injury is one of the most studied. And across animal models to humans, there is definitely evidence that high-level spinal cord injury interrupts normal cardiac electrophysiology, and there is an increase in arrhythmias. And especially that happens either in the acute setting or in the chronic setting when the sympathetic nervous system becomes activated. So during autonomic dysreflexia, for example, there are reports of increased arrhythmias in people with spinal cord injury. So yes.
Well, and I just want to complicate this further. I have a spinal cord injury. The lesion is between T8 and T10, and yet I have autonomic dysreflexic symptoms. That's not, I have a certain amount of autonomic dysreflexia, even though I'm below T6. And I just want to point out, and Dr. Krasikov confirmed this, for I actually specifically spoke to him because I didn't know what was going on. So I just want to say that there are some people who may have some autonomic issues, and they're not strictly above T6.
Yes, that's absolutely correct. And I mean, you spoke to the world leading expert on that in Andre, but I think he's actually published the only paper that I know of that exists in the literature on it, which does show that even in individuals with, injuries that extend down, I believe, to T12, he has found evidence of autonomic dysreflexia-like symptoms. And again, I don't want to go back over the autonomic versus motor versus sensory way that neurological level of injury is confirmed. But again, it could well be that, your autonomic level of injury, like it could just be in your case that maybe there's a unique topography to your injury within your spinal cord where your autonomics are affected at one level and maybe not at the lower levels, or we're still a long way from understanding, I think, truly, because we can't image it very well, how the neuroanatomy is affected with the different types and locations of injuries.
So would you happen to know what would trigger SVT and a T11, T12 spinal cord injury after 35 years of injury?
I guess I'll say I'm definitely not a cardiac electrophysiologist, so I'm probably not going to be able to offer any specifics to that. Without some kind of, more chronic Holter monitoring, ECG monitoring over an extended period of time to see how often it was occurring and if it was occurring in any particular situations or correlating it with any of the activities of daily living. That would be where I would start. But again, I'm definitely not an electrophysiologist, so that's not my area of strength. And I definitely can't give a specific answer to that one, I'm afraid.
Okay, another question that just came through. Have any studies been done on artificially stimulating the sympathetic and central nervous system in those with decreased sympathetic nervous system function to increase cardio output or even energy used during activity?
Yeah, actually, David and I were just chatting about this a while ago. And to my knowledge, there's only really been one study that I can think of that's done this. And they actually infused a drug called norepinephrine. So that will stimulate, that norepinephrine is what is usually released from our sympathetic nerves to stimulate our blood vessels, for example, to constrict and increase blood pressure. And so people have done this, or one study has done this in a lab setting where they gave norepinephrine and then immediately looked at how the exercise response changes afterwards. And they did this as a way to try and mimic autonomic dysreflexia and what is known as boosting. So that's where this boosting concept came from the Paralympics again, where athletes would artificially or on purpose induce autonomic dysreflexia to activate their sympathetic nervous system so that they can increase the output of all of these systems. And so that, to my knowledge, is the only study that's done it. And yes, it absolutely increased blood pressure and heart function and heart rate. I want to say anywhere in the region of 25 to 35 or 36%.
Wow.
So quite a profound increase, yes. And more recently now, of course, there are these other, neuroprosthetic devices such as the epidural stimulators or even transcutaneous stimulation, where you apply the stimulation from outside of the body just against the skin. And those are starting to be designed in such a way that they can also activate the sympathetic nerves in the spinal cord to do the same thing, just theoretically in a more controlled manner than, a drug delivered into the periphery might be able to do.
Yeah. So
yeah, that's important. That's common. Liz, can I say one thing on the energy side of that?
Sure.
So I do know of one study, I just looked it up again too, because at the top of my head, it wasn't there, where a dopamine infusion was used in people with cervical spinal cord injuries, dopamine being a precursor to the adrenaline, showing that there was an increase in adrenaline in response to the infusion in the people with the cervical injuries. And what was measured was the blood circulating in the fat circulating in the blood immediately in 1 hour post-infusion. So there was an effect there. There was a change in the amount of circulating fats. If that fat was being used as energy, was not measured in the study, but there's one outcome. And I will say the stimulators are coming, so get ready for those. Yeah.
So I want you both to provide a so I would like for you to highlight the ways in which exercise can make a difference for people with spinal cord injuries, even if the injury is high, because I'm getting some indications that this has been depressing because seems like nothing can be done. And I know that there is, Chris, the article that you are a co-author on talked about certain standards of exercise. And that, David, you also mentioned, in the literature, one of the things I've read is that fat utilization that you mentioned, doing exercise to increase fat utilization is of the utmost importance, because stored fat is shown to predict cardiovascular disease risks independent of activity and fitness. So I know that was a whole lot, that was a big word salad right there. So I'm talking about how much exercise would you recommend, the intensity. I'd like you to be more specific about what intensity we should shoot for, and how much time, and just to, even if you're reiterating what you said before, could you all both address that and give us some hope that we can do something to make a difference in our lives, even if we have a higher injury? Chris, you go first. How about that?
Okay, sure. Yeah, and so if it came across the way that you're suggesting, Liz, then I'm sorry. That was definitely not my intention. I am absolutely in favor of doing exercise, and exercise can be, I mean, I will take out, I'm a physiologist by training, so let me take out the socio-cultural, psychological wellness benefits of engaging in either exercise alone or with a community and being part of the shared community and everything, because they're things that are really hard to, from my perspective, to measure. From others, it's easy to measure those things, and there's clear benefits there. Every single study that I highlighted, I think, was still able to show, other than maybe the body weight supported treadmill training, that pretty much any form of exercise is good for cardiorespiratory fitness, even for those with high level spinal cord injury. If you're exercising, and most of these studies did an intervention, either physical activity or structured exercise, at least 3 days a week, then cardiorespiratory fitness, which is probably of any index the one that is most closely related to all-cause mortality, was increased with all forms of exercise, be that arm crank exercise, the combined arm crank with lower limb exercise, FES cycling, FES rowing. All of those show improvements in cardiorespiratory fitness. Now, we get into some complexities between defining all of these different outcomes. I'll let David touch on the metabolic side and the immune side we haven't spoken about as well. But certainly, I think, from a cardiorespiratory fitness perspective, absolutely. I try to give my talks now in a more provocative way that tries to take advantage perhaps of some new and emerging technologies that maybe to look at these things about how can we further augment those benefits and get benefits that extend beyond just fitness, which is really, fitness alone is really important, but maybe there are other benefits we could get if we were clever about combining some of these technologies, or even just continuing with the exercise for a longer term to try and offset some of those cardiovascular health benefits. Remember, sorry, I'll just say one more thing on this, and that is that most exercise training studies are funded through grants that have a limited time attached to the grants. And so this puts us researchers in a bit of a complex spot, because we're going to apply for funding to do an exercise intervention that we may want to target 30 people with spinal cord injury for. Now, in order to have the facilities to put 30 people through exercise, there's only so much time in a 3-year period. And so you end up almost becoming limited on the length of time of the intervention by the way some of these studies are funded. So I also think there's some infrastructural constraints that have been put on some of those studies where I just think they haven't been done for long enough to show some of the benefits. And that's why I try to take a look at this also from the athlete or the long-term exerciser lens as well. So yeah.
So my takeaway from what you said is that long-term relatively intensive exercise showed the greatest effect, including on heart health, which to me means we need to find ways to engage in meaningful exercise for a lifetime. And at least in Louisville, we have some options for that. But also, just one last thing, you said 3 days a week, but it's moderate to vigorous intensity. And I believe you've told me you use the rate of perceived effort as the standard, not heart rate.
Yeah, and just so there are many ways to look at intensity. None of them are perfect, and all of them require some form of external measurement that most people don't have access to. So honestly, there's been a lot of research in the field of spinal cord injury that has actually shown using something as simple as what we call ratings of perceived exertion scale, which is that same one you provided, Liz, which is just a 1 to 10 scale. And you should be aiming for somewhere around a 6 out of 10 on that. Now, that is with your kind of standard, moderate to vigorous, continuous activity. There exists the other forms of exercise now, such as the high intensity interval training, such as the circuit training, combining the resistance and exercise and aerobic exercise together. So I think there are many options available. We just don't have all of the answers to how effective each of those are on all of these different outcomes yet. So I would say if you are the kind of person that gets bored by doing 30 minutes of exercise at one intensity, switch it up, do some of these other types of exercise. As long as you're still arriving at a similar amount of work overall, the benefits, should come, because it really comes down to the amount of work performed.
Okay. So David, can you get specific to just circling back to you about type of exercise, how often, what intensity has an impact?
Absolutely. So we started with some constraints, talking about metabolism, and then health-related outcomes within the category of metabolism. Like we went all, forest down to the trees, down to the trees, down to the trees. And so if we said that there were some caveats, it's because we were talking about that one little tree right there, right? In general, like necessary but not sufficient. You have to do exercise, but it's not enough on its own. I think that's like the big picture take home. You can't not do this, but it's not a silver bullet, right? You have to pair it with other things. Okay, but what is it going to be really good for? Fitness and strength. Fitness meaning cardiovascular fitness, and strength meaning like isolated muscle. That's been shown time and time again. Evidence-based guidelines established in 2011, and then updated in 2018. Like that's been shown. Within the metabolic realm, what I can definitely tell you is that if you do the right kind of exercise, you can benefit your fat metabolism. And that kind of exercise is the type of exercise that is alternating in intensity. Doesn't matter so much what you're doing. You have to just strain the muscles and then take a recovery period. Don't let them fully recover and then strain them again. If I can just screen share again real quick, I think this is like one of the most important things from this whole thing is this is people with complete spinal cord injuries, right? So motor complete. So everyone in this, so it was A and B, like look at the responses. In the gray, they're working. In the white, they're recovering. They are coupled to the demands of exercise. You are getting a physiological response. You are responding. Both of these measures are relative. The peak of your response is less than mine, but you are responding if you have a spinal cord injury. I think this is really important. So relative measurements are going to change. And it's not that you can't do anything. You're doing something. Look at what your body's doing. It's so complex. Like actually, if you look at this, the VO2 and the RER are 180 anti-coupled. And so the peaks of the VO2 are happening at the end of the working period, and the peaks of the RER happening during the start of the working period. And that's exactly what I would expect if I were to run this in a lab class with a bunch of undergrads who don't have paralysis. Like, I think it's really important to know that your physiology is working for you during exercise. There's some, things where you should have some specific considerations, but like, don't be discouraged. It's just going to be with certain volume games that I think we probably could chase that, but we shouldn't. We could throw volume at this, but we're going to get to the situation where it's, I don't know where the slide is, I'll stop sharing, but it's 16 hours a week of someone trying to exercise. And then it's like, well, you have all these other things in your life, right? And so I think we should just keep that in mind. So on the metabolic side, yeah, if you do a certain type of undulating intensity exercise, it will benefit your fat metabolism, and certain evidence showing that that's both high and low injuries. But we should also keep in mind that like you should exercise for all these other reasons, right? So I think then like when it comes to the mode of exercise, like I'll just put it in the chat. There's a ton of free online services where you can just do like follow along workouts. And most of those, I call them like chair friendly workouts. I tagged them all in this giant Twitter thread, and you can just click through and find, I think there's like 36 different venues I found that'll do this. And so it's becoming more and more accessible. And a lot of these you can just do like in your home. So just like encourage everyone, like go and do this, and, you know, do it for your self-efficacy, and do it because you get to bond with people while you do it. And also it'll probably benefit your fat metabolism, right? But to decrease like total fat mass, the volume game, you have to couple it with something else.
What's the benefit? I mean, so you're talking about better fat metabolism. What is that? Why is that good?
Good question. Is it? Sounds good, right? Fat's the
Right.
enemy, isn't it?
Yes.
I don't know. A harbor seal exists at 60% body fat, and they look pretty healthy, athletic too. Fat as a fuel source, I mean, you can make arguments. It's, you know, bioenergetically more efficient in certain ways, less efficient in other ways. I think in general, using fat as a fuel source, like, I'm kind of agnostic there. Like, unless you have really specific goals, fat as a fuel source might not be the thing for you. If you like were some type of muscle cell and you had conscious control over your own metabolic processes. In general, for a health perspective, if we want less fat floating in the blood, because a prolonged period of fat in the blood, if that fat is turned into a certain form, chemical form, it can interact with the blood vessel walls, and that might result in the blood vessel walls becoming damaged in certain ways that can result in cardiovascular disease. So in the long term, if we cause a gradient so that the fat is being utilized in tissues other than the blood, it's not used in the blood. Actually, blood cells can only use sugar as a fuel source. It leaves the blood, then it's not sitting in there getting transformed into these detrimental forms that interact with the blood vessel wall. So from a health perspective, that's what we're assuming is happening. You pull the fat out of the blood and use it in other tissues, it's not in the blood to do the damage to the blood vessels. So that's the idea there. But
I have two pretty good questions here, and we have 7 minutes, just so you know. So here's one. It was mentioned that after spinal cord injury, musculature can become marbled with fat. Is this something that can be corrected or minimized with exercise?
yeah, there are some studies showing, especially with the lower extremity muscle fat infiltration, where the muscle both atrophies due to the paralysis and the fat goes in between it. That if you use certain forms of electrical stimulation for the lower extremity muscles, that you can change that situation there, the composition situation. The relative proportion of fat and muscle, fat tends to grow. I'm sorry, the muscle tends to grow. The fat changes a little bit less, but relatively it decreases. So that can happen if you have access to that equipment. A lot of people don't, right?
Yeah.
And so I have never seen a study where exercise in a muscle that wasn't the one being measured for the fat changed the muscle and the fat.
I see.
So doing arm exercise, I'm not sure that will change your leg fat composition.
And any advice on a balanced weight training, exercise routine, exercises and time frames to prevent overuse injuries in higher level spinal cord injuries like C6 or higher, I guess?
I mean, I can tell you just practically what we tend to do is 3 days a week of the circuit. The circuit has a lot of emphasis on pulling instead of pushing. And then any cardiovascular exercise that's done both for the circuit or outside of it is just something that doesn't resemble pushing in a wheelchair if you push in a manual chair. If you have a power chair, C6, right, you might have a power chair. Then I'm not sure, like it depends on your transfer technique, what you're doing at home, these types of things. But you might have like a little bit less emphasis on avoiding a wheelchair type resistance, or I'm sorry, endurance movement. And so we tend to put these, we try and get a day in between each of them so that there's a recovery period. And then if you can, I would say like the single best thing to do would be to alternate the circuit resistance exercise with something like FES, a lower extremity type movement. But like then now you're already talking about tons of access to equipment. So from a practical standpoint, what do you do? I can tell you we have adaptations of this circuit that just require elastic bands and one helper. And we've had multiple studies we published showing these methods. And we also have ongoing studies right now funded by like the United States DOD to implement some of these things to try and make this mode a little bit more accessible. So if you have individual questions about this, like I could give a whole, 2-hour talk on like just how to do that. It's pretty nuanced. But like, yeah, you can definitely contact me. We have multiple interns right now doing this right now, and postdocs for the DoD. We can like, zoom you in and show you what's going on. I don't know. So we'll figure something out, but
Yeah, well, I wanted to get into that study you were doing about using resistance, but doing a circuit resistance training used at home with resistance bands. We don't really have time to get into it, but I definitely want to provide resources to folks who came to this, links to studies. I'm not sure if all these studies you've mentioned are free or whether we can provide them for free. And then I also just want to point out for people who are in Louisville, we do have Gathering Strength provides online exercise, adapted exercise classes. And now that I know all this, we may try to craft some that do this interval training more. And also the Community Fitness and Wellness Gym has, FES and neuromuscular electrical stimulation and wheelchair accessible weight training. And now it is fee for service, but it is a resource where we could create these types of modalities for folks and find ways to, to provide the most effective regimens for people to improve their health. And so anyhow, I just want folks to know there are resources, at least around here, and Gathering Strength is trying to provide them online. And David, I might hit you up for how to develop something online, a virtual class that would be most effective. So let's see, wait a minute, did I miss any? Let me look. No, I did that with Chris. All right, folks. Well, holy moly, it's 6:58, and that sort of timed perfectly. Unless someone has just a burning question right now, of course, you can always email me, and we'll try to find answers. Anybody have a burning question they didn't ask? Sue, are you waving or do you have a question? Just waving. Okay. All right. Well, thank you so much, Chris West, David McMillan. This was incredibly interesting for me, and I think everybody who was able to join us. My wheels are turning about doing another one of these where we do go in depth on a particular topic to provide people with more, how to do it. So anyhow, thank you very much. Appreciate your time. And if anybody has any other questions, please email the Gathering Strength email that was on all the marketing emails that went out. And I'm always happy to help and always interested in this topic. And I thank you all again, and I will say good night and have a lovely evening, and stay inside if you're anywhere in the Louisville area where it's so stinking hot. All right,
here
folks.
All right, thanks all. Bye.
See
Thanks
ya.
so much, everybody. Thanks for all the good questions as well and the
Here, here.
interaction.
Yeah. All right. See you later.